Hello and welcome to our new topic. Today we will discuss the pharmacological treatment of asthma and chronic obstructive pulmonary diseases or COPD, two major respiratory conditions that share certain features yet differ fundamentally in their pathophysiology and management strategies. Asthma is primarily an inflammatory disease with reversible airway obstruction, whereas COPD represents a progressive and largely irreversible limitation of airflow. Understanding these differences is essential, because pharmacological therapy must be tailored not only to relieve symptoms but also to target the underlying mechanisms driving disease progression. So, let's start. At the end of this lecture, you are expected to understand not only the classification of drugs used in asthma and COPD, but also the rationale behind their use. You should be able to explain how each class of drug works at the molecular and physiological level, recognize their adverse effects, and most importantly, apply this knowledge to choose appropriate therapy in different clinical scenarios. The final objective emphasizes the importance of local and international guidelines, which increasingly shape modern evidence-based prescribing. Asthma is defined as a chronic inflammatory airway disease characterized by episodic bronchoconstriction and airway hyperresponsiveness. These features are driven by immune mechanisms, particularly involving type 2 inflammation. In contrast, COPD consists of chronic bronchitis and emphysema, where structural damage and airflow limitation predominate. Chronic bronchitis is characterized clinically primarily by persistent productive cough, while emphysema is characterized pathologically by alveolar destruction and respiratory tract abnormality. These distinctions are important because they influence therapeutic targets. Despite their differences, asthma and COPD share key features such as airway narrowing, mucus hypersecretion, and inflammation. These shared mechanisms explain why certain drug classes, such as bronchodilators and anti-inflammatory agents, are useful in both conditions. However, the degree to which each mechanism contributes differs, and this determines the relative importance of each drug class in treatment. Drugs used in asthma and COPD can be broadly divided into relievers and controllers. Relievers primarily act as bronchodilators and provide rapid symptom relief, while controllers modify the underlying disease process. This distinction is critical, because reliance on relievers alone does not control disease progression. Modern therapy increasingly emphasizes controller medications, especially inhaled corticosteroids. So basically, there are three groups of drugs. Anti-inflammatory corticosteroids, inhaled, provide the primary element. The relievers are used in addition to induce bronchodilation, and finally, biological agents are used to target stubborn inflammation. Let's talk about the relievers first. Beta-2 adrenergic agonists act by stimulating receptors on airway smooth muscle, leading to increased cyclic AMP and relaxation of bronchial muscles. This results in rapid bronchodilation. While these drugs are highly effective for symptom relief, they do not address underlying inflammation and hence only have a temporary and secondary importance. Their side effects, including tachycardia and tremor, are generally dose-dependent and reduced with inhaled administration. Short-acting beta agonists, or SABA, provide rapid relief and are essential in acute asthma. Whereas, long-acting beta agonists, or LABA, provide sustained bronchodilation and are used for maintenance therapy. However, it is crucial to emphasize that LABA should never be used alone in asthma, as they do not control inflammation and may worsen outcomes. Their use must always be combined with inhaled corticosteroids. This diagram illustrates the intracellular signaling pathway of beta-2 adrenergic receptor activation. The increase in cyclic AMP leads to activation of protein kinase A, which reduces intracellular calcium levels and inhibits myosin light chain kinase. This results in smooth muscle relaxation. Understanding this pathway helps explain both therapeutic uses, effects, and drug interactions. Methylxanthines, particularly theophylline, act primarily by inhibiting phosphodiesterase, thereby increasing cyclic AMP. Hence, they show synergistic effects with beta agonists. They also influence histone deacetylation, which has anti-inflammatory effects. These drugs show synergy with other drugs, such as steroids and beta-2 agonists. However, their clinical use is limited by a narrow therapeutic index and significant adverse effects, including arrhythmias and seizures. Hence, their role today is largely adjunctive. Anticholinergic drugs block muscarinic receptors, particularly M3 receptors, leading to bronchodilation and reduced mucus secretion. These drugs are particularly important in COPD, where cholinergic tone plays a dominant role in airway constriction. Long-acting muscarinic antagonists or LAMA, such as tiotropium, provide sustained bronchodilation. The combination of LABA and LAMA produces synergistic bronchodilation by targeting different pathways. This reflects a key principle in pharmacology. That is, combining drugs with complementary mechanisms enhances efficacy while minimizing toxicity. This approach is especially useful in COPD management. This slide shows how beta agonists, methylxanthines, and antimuscarinics synergize with each other. Inhaled corticosteroids are the cornerstone of asthma therapy. They reduce airway inflammation, decrease hyperresponsiveness, and prevent exacerbations. The inhalational route reduces the dose requirement and hence also reduces side effects. Inhaled corticosteroids are routinely used in combination therapy regimens. Their pharmacokinetic properties determine systemic exposure, with newer agents having improved safety profiles. Local side effects such as candidiasis can be minimized by proper inhaler technique. Growth retardation is a real concern in children after long-term use. Cromolyn acts as a mast cell stabilizer and is used prophylactically. Although less commonly used today, it illustrates an important concept: preventing mediator release rather than reversing bronchoconstriction. Leukotrienes are potent mediators of bronchoconstriction and inflammation. Take time to explore this mechanistic diagram. Drugs targeting leukotriene pathway either inhibit synthesis or block receptors. Relevant examples are shown. Montelukast is widely used due to convenience and safety, while Xylutin is limited by hepatotoxicity. Functional classification of immune response is based on the need to cater the threat, such as pathogens or allergic response. Type 2 immune response targets allergens and multicellular parasites, in contrast to Type 1 that targets intracellular infections caused by viruses and bacteria. While Type 3 targets extracellular bacteria and fungi. They all show a predilection for different immune cells and cytokines. Type 1 depends on macrophages and natural killer cells, Type 2 on eosinophils, basophils and mast cells, while Type 3 on neutrophils. Lymphocytes play a role in all three. In asthma, especially allergen-induced asthma, Type 2 immune response plays an important role and hence, inhibiting it helps to stop the pathogenesis. This slide shows why a respiratory viral infection among asthmatic patients may lead to asthma exacerbations. Eosinophils adversely affect this situation and provide a reason to switch to biological agents in difficult-to-treat asthma patients when eosinophil counts are high. Biologics target specific points in Type 2 immune pathway, as shown. This represents a shift from broad, non-specific immunosuppression to precision medicine. Omalizumab is the prototype drug in this group. It targets immunoglobulin E, while other agents target IL-5, IL-4, IL-13, or upstream mediators such as TSLP. The choice of biologic depends on phenotype and biomarkers. These drugs are reserved for severe, uncontrolled asthma due to cost and specificity. The next two slides show a comparison between various biological agents used for allergic asthma. Please take time to explore them. The modern guidelines suggest that before starting treatment of asthma or COPD, a clear list of therapeutic goals should be identified based on physical examination, blood eosinophil count and FeNO testing. Clinical determination of disease severity is fundamental. A careful history and physical examination is mandatory. There are tools available to gauge disease severity, as shown in this slide. Management of acute asthma requires rapid assessment and aggressive treatment. Oxygen, bronchodilators, and systemic corticosteroids form the core of therapy. Adjuncts such as magnesium sulfate are used in severe cases. Early intervention is critical to prevent respiratory failure. The stepwise approach in Global Initiative for Asthma emphasizes escalation of treatment based on symptom control. The key principle is achieving maximum control with minimal medication. Importantly, biologics are introduced only after optimizing conventional therapy. This slide shows a more detailed account of GINA's stepwise approach. Take time to explore. Most of the times, the inhaled drugs are usually self-administered through inhaler devices. This slide shows how various types of inhalers differ from each other and suggests specific techniques for each one. COPD classification is based on FEV1 and symptom burden. Treatment focuses more on bronchodilation than inflammation. Combination therapy and stepwise escalation are central, with biologics playing a limited but emerging role. This algorithm is for drug treatment of COPD. See the triple therapy approach as depicted by LABA plus LAMA plus ICS. In conclusion, the pharmacological management of asthma and COPD requires an understanding of both disease mechanisms and drug actions. Modern therapy increasingly emphasizes individualized treatment based on phenotype, biomarkers, and clinical response. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!